100th anniversary. He was so excited about the 100th anniversary, but sadly passed away about 3 years ago. Chris Ruddy is one of the most knowledgeable people on the history of the discovery of insulin. He was a PhD student with Michael, and it's been a source of a lot of information for me. This is just an abbreviated version of a paper that we published in the Journal of Clinical Investigation earlier this year, if you want to read a little bit more about the discovery of insulin. So prior to 1922 and 1923, when insulin started to become much more widely available, type 1 diabetes was an absolutely shocking illness. It's still a very difficult illness to have. It does require lifelong management. There is the risk of some diabetic complications, but then before the discovery of insulin was uniformly fatal. And these tragic photographs that you see of these young children looking like concentration camp survivors, they would basically waste away, sometimes, and with a condition called ketoacidosis, where there was pretty much nothing that could be done. There were a lot of diets that were tried, very low carbohydrate diets. They were very restrictive, very difficult diets for these kids to stick to. And in some cases, their lives could be prolonged by months, but invariably they would succumb to the illness. And there were also some adults who developed type 1 diabetes. So this is just the most beautiful quote this is Michael Bliss, who I mentioned to you, and this is from his book. And I'll read it to you because it's quite an incredible quote. The discovery of insulin at the University of Toronto in 1921-22 was one of the most dramatic events in the history of the treatment of disease. Insulin's impact was so sensational because of the incredible effect it had on diabetic patients. Those who watched the first starved, sometimes comatose patients with diabetes receive insulin and return to life saw one of the genuine miracles of modern medicine. They were present at the closest approach to the resurrection of the body that our secular society can achieve, and at the discovery of what has become the elixir of life for millions of human beings around the world. So for those of you who've done any research, you'll know that great discoveries very, very rarely will just come right out of the blue. Researchers stand on others' shoulders and learn from a huge body of research and develop their theories and test their hypotheses based on lots of work that has come before them. And that was the same situation for the discovery of insulin in 1921. So we can probably take the story back to Paul Langerhans in 1869, about 30 years before, just over 30 years before, where he actually discovered these clusters of cells that were free-floating in the pancreas. These clusters of cells, the islets, that were free-floating in the pancreas and distinct from the acini, which are the glands that make the exocrine enzymes that are secreted through these little ducts and then into the pancreatic duct, into the duodenum. And so the acini, which is the majority of the pancreas, secrete these enzymes to digest the food. But then there are these other clusters of cells, and they subsequently became known as the islets of Langerhans, the islands. And Paul Langerhans didn't really know what the purpose was, but he really discovered them. And that was a very important discovery. Equally important, around about the same time, there were researchers who started to localize an internal secretion to the pancreas. So most notably Minkowski and von Mering in 1889, and Hayden in 1893. And they reproduced the diabetic state by removing the pancreas from dogs And they hypothesized that this was due to a loss of an internal secretion of the pancreas, rather than these pancreatic exocrine secretions. And they actually put back a small graft of the pancreas and corrected the diabetes in the animals. So these are really fantastic experiments. One might even suggest that, you know, this kind of work was worthy of a Nobel Prize. And they even started to do some work with crude pancreatic extracts, but they struggled with very limited success to really lower. And at that stage, they were measuring the urinary glucose, difficult measurement, and they had very little success in actually correcting the diabetic state. But this was the beginning of localizing this internal secretion to the pancreas. So Eugene Opie in 1901 at Johns Hopkins actually did some pathology on people who had died from diabetes. And he saw this inflammation in the pancreatic islets, okay? And he linked this inflammation of these islets that Langerhans had discovered more than 10 years before with the diabetic state. And then there were many researchers in the 20 to 25 years prior to the work of Banting, Best, McLeod, and Collip at the University of Toronto, who really worked on this and tried very hard to isolate this internal secretion and develop a therapy for diabetes. And I won't go through all of them, but here are the names of some. Now, Paulescu does deserve mention. He was a Romanian scientist, and he actually published his work in 1920, just before or as Banting started his experiments in Toronto. And he had quite a lot of success, actually, in administering an extract to dogs and actually reducing their blood sugar. So he did that and he published it really before the Toronto group did. He really struggled though to create a pure toxin-free extract for administration to humans. So he did not succeed in administering insulin to humans without great toxicity, and eventually gave up his work a couple of years later. But the Romanians really were very upset about that, and they really felt that he was overlooked when the Nobel Prize went to the Toronto group. And the Nobel Prize Committee reviewed it, they rejected it. This story went on for years, but Paulescu was one of many, actually. I mean, Zulsa himself, they were administering even to humans some of this extract prior, but none of them had success in developing a pure toxin-free extract. And so the story is Fred Banting had come back from the First World War, where he had done surgery with obviously all the trauma of the First World War. There wasn't really a specialty of orthopedic surgery at that time, but if anything, he might be considered an orthopedic surgeon or general surgeon. And he was trying to set up a clinical practice in London, Ontario. And he was really struggling, in fact, struggling financially and struggling to get patients. And 6 months, and he was getting very frustrated with, I think he saw one patient in 6 months or something, so having a very difficult time. Anyway, he was giving some lectures at the university and he was preparing for lectures. And he read about this case where a stone blocked the pancreatic duct, and then there was some involution or atrophy of the exocrine part of the pancreas. And he thought to himself, and he jotted this story down actually in the middle of the night, that and it reads, the idea or the hypothesis is that if you ligate the pancreatic duct of the dog and then keep the dogs alive till the acini degenerate, that will leave the islets, because these pancreatic enzymes would degrade peptides or degrade any substance, the so-called internal secretion, which by then people thought might be coming from the islets, that there was something there. And the concept of hormones was already developed by that time. And that if you ligate or tie off the pancreatic duct, and then the rest of the pancreas, the exocrine part, degenerates, that would allow one to isolate this internal secretion intact, and then administer it and relieve, as he said, glycosuria, which is actually misspelled, but I've written it exactly as he wrote it. So this was Banting's idea. As I'll show you, actually the hypothesis is incorrect, okay? So one does not need to ligate the pancreatic duct, but this really set things in motion. He went and spoke to one of his colleagues about his idea. It was very exciting. He had no research experience, none, no research training or anything. And his colleague in London suggested he go and speak to MacLeod, who was the head of physiology and really an internationally known carbohydrate researcher at the University of Toronto. He said, go and speak to MacLeod and tell him about your idea and ask him what you'd like to do. So this was in 1920. You can see this idea was in October 1920. And so he went off to the University of Toronto, and this is J.J.R. MacLeod, a very esteemed, established carbohydrate researcher. He had lab space, he had resources, and he was unimpressed with Banting and didn't really want to give him resources, but eventually kind of relented, and he suggested that he come to Toronto and he would give him lab space, and also gave him a graduate student at the time, Charlie Best, who won a coin toss with his friend and then got to work with Banting. And this famous photograph of a dog on the roof of the medical building. This is very interesting. This is a calorimeter to really measure glucose. And this was really quite an advance, this big, sort of now old-fashioned thing, but it really gave an advantage to these researchers over and above the previous researchers, because they could actually measure glucose in the blood, now in smaller aliquots of blood repeatedly with more precision than others. So that was a big advantage. And, Banting had a lot to deal with, and he had a relationship there, which was also not working out. And maybe the dissolution of that relationship was probably what pushed him to move to Toronto. He didn't get a salary. That was a point of great concern for him, and started to do, but very, very motivated, do these experiments. It was a boiling hot summer, no air conditioning at that time, very uncomfortable. And they started to do these experiments in the dogs, and Banting, of course, had the surgical expertise, and he would ligate the pancreatic ducts and then they would wait about 7 weeks for involution of the exocrine pancreas, and then take that, remove the pancreas, mash it up, make a solution, and try and inject it back. And they had lots of failure. I mean, just failure after failure. If any of you have had bad experiences in research, your experience may not have been as bad as Banting and Best. Okay, it was very dispiriting. Anyway, around about August, they started to get success. And this is the graph of urinary glucose from a dog, where they started to see some reduction in the urinary glucose. And this is Banting's notes, lab notes. And they worked through that summer, and MacLeod actually went back to his native Scotland, where he spent the summer, and I think he had a cottage there. And he was in communication, but that, no email then, a letter would come on a ship kind of thing. And I'm not sure what the status of telephones was, but anyway, poor communication. And he gave some advice, but in the fall, he started to really direct the experiments. And I'll tell you how they moved from the ligated duct to just the whole pancreas. I'll come to that in just a minute. But one of the big advantages was there was a biochemist by the name of Collip, and Collip was a really outstanding biochemist who was on sabbatical in Toronto from the University of Alberta. And he was working he was doing a sabbatical in McLeod's lab. And in December 1921, McLeod asked Cullip to become involved in these studies. And so that's when he started, and he used an alcohol extraction method. And it's like baking a cake. I mean, you got to get it just right. The pH, the temperature, the alcohol concentration can't be too low, can't be too high. It has to be just over 90%. And he started to get success. And he also started to use rabbits, which made it much faster. He was not ligating the duct. He was taking whole pancreas. He was trying to extract this active substance in a purified form and get rid of the impurities, and using a bioassay of injecting it into the rabbits with huge success. And so soon, even in January 1922, they felt they were ready to administer this extract to a human, the first human. And with some dispute, there was already starting to become some bad feelings between Cullip and McLeod on the one hand, and Banting and Best on the other hand. And Banting insisted on using his and Best's extract, which was less pure, and they gave it to this young boy, Leonard Thompson, who was dying of type 1 diabetes. And he 14 years at the time, and they gave him the first extract, and he was in ketoacidosis, and it had very little benefit, this first injection, almost no benefit, and large volumes, 3.5 cc's into each buttock, caused sterile abscesses, must have been incredibly painful. Not much happened, so they sent Cullip back to the drawing board, and I think Cullip and McLeod were upset that they had used Banting's extract. So, a few days, just over a week later, on January 23rd, with Cullip's more purified superior extract, they administered it with incredible results and an improvement in clinical well-being, and off to the races. That was the first really successful administration of insulin. So we've drawn this timeline, and you'll see this in that JCI paper. So you can see here, we place Cullip, McLeod, Best, and Banting, all four of them, here in the timeline. So it's not as if this, there was zero before them. There was a lot of work, and here's Paulesco, who I mentioned, and many of the others. I'm not going to go through them, but there was a lot of work that led up to this. And then this wasn't really actually the discovery of insulin. This was the purification of insulin to a point that it could be safely administered to treat type diabetes. But the discovery actually came through the next part of the century with a number of Nobel Prizes that includes the amino acid sequence of the hormone insulin, the peptide sequence, eventually the genetic sequence, the crystal structure, its mechanism of action, the radioimmunoassay. Rosalind Yellow got the Nobel Prize for that with Berzin, and she worked on that in the 1960s. So tremendous advances over the next part of the century of purification and structural characterization that you could argue this was not actually the true discovery of insulin, but it was its purification. So the question is, was the 1921-22 work in Toronto the true discovery of insulin? Because I've told you, others were working on it before, and some of them with some success. And then there were people after them who did a lot of work too. But we've come to the conclusion that really what is absolutely beyond dispute, and nobody will dispute that, is that Banting, Best, Cullip, and McLeod were the first to develop an insulin preparation as an effective therapy for humans affected by diabetes, and no other investigators or groups can lay claim to that accomplishment. So what were the success factors of these Toronto researchers compared to their predecessors? Why did this happen in Toronto? They made, there were lots of great advances. Well, first of all, we must acknowledge that there was already a large body of knowledge that had already localized an internal secretion to the pancreas. Banting was not simply a curious researcher, but he wanted to, if possible, in his own words, isolate a form of internal secretion that will be of use in treating diabetes. And so his sheer drive, determination, perseverance, laser-like focus on developing a successful treatment for diabetes was really his success factor. A lot of people would have given up in that summer of 1921. That was tough, right? But this guy, he wanted this thing and he was going to get it. So he was the driving force, even though he didn't have the research background. There was a lot of personality issues, in terms of subsequent breakdown in relationships. I think Banting must have been responsible for a lot of that, but he was amazing in this way. I told you already that actually they had an advantage of being able to measure more precisely in smaller volumes repeatedly blood glucose, and perhaps if this technique was available to their predecessors, they might have realized they had more success than they thought they did. One has to credit MacLeod with his experience, etc., and guiding the research. Banting didn't give him any credit, and you'll see when he got the Nobel Prize, he was furious that MacLeod got it. Like, for example, I'm the director of the Banting Best Diabetes Center. I don't get a Nobel Prize if someone who works in the diabetes center has a great discovery. And so that was the attitude that Banting had to MacLeod, is that he didn't contribute. But actually research suggests otherwise. I think he had a lot of contribution. And so he deserves a lot of credit. And then of course, Collip, so some people say, well, it was all Collip. But Collip wouldn't have done this if the others hadn't been there, right? So all four of them played a very important role. So indeed, Collip's, that was the actual purification and getting the toxins out of it. And he was, just superb. And that's what a chemist does, okay? So he played a major role. And then, as I'll talk to you in just a minute, the collaboration with industry to scale up production. So now, all of this news gets out that they've got a cure for diabetes, and the whole world is like on their backs wanting insulin, and then what, right? So I like to talk about this because it's interesting to me, and it's about this common pitfall in research, and that's believing one's hypothesis to the point that it impairs judgment. And so the question is, how did Banting slowly come to abandon his central hypothesis that ligation of the pancreatic duct would result in degeneration of the exocrine pancreas, enabling isolation of the internal secretion? So they started to, in the fall of 1921, they started to have delays because they could only generate these animals at a certain rate. And then it took 4 to 7 weeks to wait for the duct-ligated dog's pancreas to involute or degenerate. And so they started to take some shortcuts, and they started to use pancreas that was at shorter and shorter timeframes. So they used the pancreas from only partially degenerated pancreas. They made the extract, and they actually had some good results. But very interestingly, they failed to recognize their own findings, okay? And so in their publications, they claimed that the duct-ligated pancreas worked better, but the data didn't show that, okay? So that's what I mean about believing your hypothesis to a point that you're not being led by the data. And it's so important, when I'm in graduate student meetings, sometimes the grad students will say, we set out to prove this hypothesis, and I stop them right away. Hey, stop. No, you did not set out to prove the hypothesis. You set out to test the hypothesis. The hypothesis is just a thought. It's just an idea. It may be right, it may be wrong. In fact, in most cases, hypothesis is, and you're testing the null hypothesis anyway, actually, and trying to see a difference from that. So in many, many cases, you're not correct, but that's very important advance in science as well. Okay, anyway, they started to pivot, and also McLeod was saying to them, he wanted to see longevity experiments in the dogs. So he wanted to see more than just a single dose of this extract lowering glucose. He said that the real proof would be if you give repeated insulin, can you improve the well-being of the dog? Can you make it survive longer? That's what I mean by longevity. And so they were running out of extract. And so he read a paper showing that newborn or fetal pancreas had more plentiful islets. And he had grown up on a farm, so he knew that farmers will often breed their cattle before slaughter. And so there would be many pregnant cattle, and he would not have a problem getting fetal pancreas from the abattoir. And they went, him and Best, and they got these fetal pancreas. They had very good success. And then finally, they resorted to using a pancreas of a non-ligated adult pancreas from a dog with very successful decline in blood glucose. So that's sort of, no longer did they really need to ligate the duct of dogs. And then subsequently, insulin was derived from pigs and beef, okay? And why did they not, another very interesting thing is, why did they not attempt to profit personally from the discoveries? So this is very interesting. So it's well known that they sold their rights to the University of Toronto for $1 a piece, and the university filed an application for a patent. Their reason was they felt that providing their patent to the university would prevent the discovery from being commercially exploited by a single company. And justification for filing a patent was that when the details of the method of preparation are published, anyone would be free to prepare the extract, but no one would secure a profitable monopoly. So University of Toronto was worried that if they didn't patent it, and they had lots of debate, should they or shouldn't they patent it, that they could, someone else could patent it, and then they could not make this available to everybody. And the discoverers were actually very reluctant to be associated with patenting on ethical grounds that commercialization might make their discovery unavailable on a widespread basis. And Banting famously declared that insulin does not belong to me, it belongs to the world. And they had very high ethical concern, and it reflects the time and the day that ensured that even the most financially destitute of patients would not be deprived of insulin by commercial forces. And this discovery of insulin provided a formative test case for the relationship between academia and industry. And it's just interesting to reflect that unlike today, in which commercialization of medical discoveries is actually a point of great pride for researchers and universities, it's sort of like the ultimate success, right? In 1921-22, researchers and universities felt very uneasy about profiting from medical discoveries, which were first and foremost to benefit humanity. And so this was one of the fastest awarding of Nobel Prize about 18 months later, in the end of 1923. And actually, you'll see here the certificate. In contrast to what a lot of people believe, it was not awarded to Banting and Best, it was awarded to Banting and McLeod. But anyway, by then their relationship had deteriorated to such a point. Banting was furious, immediately split his award with Charlie Best, and McLeod split his with Collip. And ultimately, all four of them really deserve the credit for this. And I'll just say, I've cut out slides because I want to do the second part of this talk quickly. But the relationship with industry was very interesting, and we do deal with it more in the manuscript. But the Eli Lilly company in Indianapolis and its medical director, Klaus, were very interested. They heard Banting's presentation at the end of 1921 to, I think, the American Physiologic Society of the success that they were having, and he kept in contact with them. And then when they had this breakthrough in January 22, Lilly had a deal with the University of Toronto, and there was huge collaboration. And the Toronto group was struggling to make insulin available for all these patients that were dying, and particularly children. And their production actually started to fail. in the spring of 1922, and Lilly had some developments like isoelectric focusing, etc., and eventually were able to provide massive quantities of insulin so that by 1923, there was sufficient insulin. So anyway, I won't go into that much more. So pivoting on to, so the advances in insulin and diabetes treatment over the past 100 years, there have been a lot more advances since then. So insulins have become much purer, more concentrated, less side effects. Some insulins have been modified and they have delayed absorption from subcutaneous. So insulin would otherwise be quite rapidly absorbed and then gone. So by delaying this absorption, you can give insulin less frequently through the day and provide different kinds of kinetics. Advances, of course, in self-glucose monitoring, including capillary glucose testing, and has been a tremendous advance, the development of the hemoglobin A1C to monitor diabetes control. Now we have improved insulin delivery devices, pens and infusion pumps. The first insulin, human insulin, was manufactured again by Eli Lilly in 1982. It was a tremendous advance. So no longer do we use insulin derived from beef and pork. We have extremely long-acting insulins. In fact, there's now an insulin under development that lasts a whole week. You give it once a week. There are disadvantages to that too, but that is now being developed. So we have these insulins that last, 24, 48 hours, and we have very rapid insulin. So someone lacking insulin, you try to mimic the kinetics of insulin secretion, and it has to be more rapid than what used to be called regular insulin. And of course, now we have continuous glucose monitoring, which was a tremendous engineering feat, was very difficult to achieve for years, but now there are continuous glucose monitoring devices. Now, cost and availability is a big issue with these across the world and in Canada. But the Holy Grail for type 1 diabetes, so remember, type 1 and type 2. Type 1 diabetes is an immune reaction where the pancreas, the insulin secreting cells get destroyed, and then there's no insulin secretion, and it can be quite insulin sensitive. Whereas type 2, the 90%, they still secrete insulin, but not enough to overcome the insulin resistance. So type 1 diabetes, very, very difficult to manage, very difficult. And you need physiologic insulin replacement. And nothing that we've currently got is as good as a pancreas that's measuring not just glucose, but other metabolites and secreting the insulin into the portal vein. And here, insulin is administered subcutaneously into the systemic circulation. But hooking up a continuous glucose monitor with an insulin pump connected by an algorithm is what's called a closed loop system. Now, it's not yet available on the market, but it's very, very close. And within just, it exists in the sense that, there is a whole community out there of a do-it-yourself group of people and parents with children of diabetes who actually, so the algorithms exist, and they actually have jerry-rigged these things so that, it's sort of like plug and play, but they're not approved. So to get something approved through regulatory bodies takes billions of dollars. But essentially, this is an engineering thing that has, I believe, been solved and will be available soon. But again, reimbursement is a major, major issue. And then there's cell-based therapy, stem cells, islet cells, transplants, etc. And this is the holy grail, and hopefully, nothing can work as well as a cell, but it's also a tough nut to crack, but it's being worked on. Okay, so second part of talk, okay, and it's shorter. Where do we go from here? And what are the challenges we face? So what I've talked about to date are the discoveries. Okay, and there's tremendous advances and discoveries, okay, and they're ongoing. And I can tell you, I practice mainly, I care for people with type 2 diabetes. And we have a whole slew of medications. I can hardly remember the names, and they all get combined with each other, etc. And we have tremendous advances in the therapy. But here is the problem. Public healthcare systems are overburdened with person power shortage, long waiting times, infrequent structured evaluation, and insufficient patient engagement. So this is a major problem. Annual growth of healthcare expenditure exceeds that of GDP growth, calling for more efficient and value-added care. And even in high-income countries like Canada and areas with medical coverage, large patient volumes, complex care protocols, frequent changes in healthcare providers, lack of regular evaluation, and insufficient patient engagement can lead to delayed intervention, suboptimal self-management, and patient distress with poor clinical outcomes. So I am very involved in some of this now, and Elizabeth mentioned this organization that I lead, which is a CIHR-funded national diabetes network called Diabetes Action Canada, where you can look at the website, and we're involved in a lot of these issues, trying to solve these problems. The group that's done this best is our colleagues from Hong Kong, particularly Juliana Chan, absolute world leaders in that. Now, they have some advantages over us. It is one territory with, it's not like Canada, which is sort of the wild west of medicine with so much fragmentation, etc. But they've done a fantastic job in Hong Kong, and I'll show you that. Just trying to advance my slide. There we go. So due to the high patient healthcare provider ratio, use of information and communications technology and non-physician personnel can improve the efficacy and continuation of care delivery. So let me just tell you what it's like. As I have a clinic and I take care of people with diabetes as well as lipid disorders. And so I have about 15 minutes for follow-up of a patient. And in that 15 minutes, I have to be superbly prepared. Okay, so I don't do a lot of clinical work because I have a lot of other academic work. So I employ an administrative assistant all week long to really prepare my sort of 2 half-day clinic. I mean, it's ridiculous, and it's a luxury that most people can't afford. And so people know when they're coming to visit me, and when I finish seeing them, we make another appointment for 4 months or 6 months. We send a reminder letter. They get their blood test done before they see me, and I have the blood test then entered in a flow sheet. Okay, and so I have a lot of information, and my records, have to be good. So I have to remember exactly that I did that last time or that next time. And in that 15 minutes, which also includes, hello, goodbye, getting people in the room and checking I have to do a lot of things, too many things. I have to do therapeutic maneuvers to optimize 3 major things: their glucose, their LDL cholesterol, and their blood pressure. It's evidence-based medicine shows huge benefits and improving life and everything and reducing complications by doing that. And there's a lot to do with that, to assess that and do that and make sure I do that in the context of their renal condition. I have to examine the feet and look for complications. I have to make sure that their eyes have been checked, and I have to check their blood pressure, etc. There's no time left for me at all to address issues like mental health issues, mood, many of the social determinants of health. There is simply not the time, and I don't have the skills. So I am not practicing good and comprehensive medicine. So and this is a big, big problem. We have to do better with that. And so multi-component, data-driven integrated care assisted by non-physician personnel, information and communications technology has been demonstrated, particularly by this Hong Kong group, to cost effectively improve hard clinical outcomes by 30 to 60%. And data stratify risk, triage care, empower patients, and individualized treatment. So So not everybody of the 3.5 million people with diabetes in Canada are in big trouble from their diabetes. In fact, it's really those with the social determinants of health that have most of the issues, okay? And so you can see there's a lot of modifiable and some non-modifiable risk factors for diabetes and its comorbidities, but I want to really make this point here. It's this access to care and drugs, access to education, self-management, emotions, lifestyle, ongoing support. These are the things that are being ignored by our healthcare system that we simply cannot manage, right? And these and the social determinants of health. So the same people who did very badly from COVID, many of those people are going to do very badly from diabetes. We know that, okay? So it's the elderly, it's indigenous people, it's people living in poverty, it's new immigrants, it's women and single women and all those groups. Those are the people who are these high-risk people. So what they've done in Hong Kong and what we need to do with big data, and we struggle in Canada because we don't have the data sets and every system's different and privacy issues, is to segment our population into risk levels so that we can address those at the highest risk and direct a lot of our resources to the highest risk individuals. Because I can tell you, it's a small segment of this population that's driving up costs and it's going to land up with amputations, etc. So these are just data that show that prospectively, by doing this with these data-driven segmenting the population and then this comprehensive care have actually improved many of the outcomes. Okay, and so a virtual, and we pivoted very fast during COVID to virtual care, like within 2 weeks. We suddenly were thrown out of the hospital, last March 16th, it was out, go home, and I got all these people that I have to follow, and we just started taking care of people on the phone. And what enabled that was the Ministry of Health allowed us to bill for telephone calls, etc. And but there are limitations to how we conduct that virtual care. We have to do much better. It's not good enough me just getting on the phone one-on-one with a patient. But there are some advantages. It eliminates and reduces need for face-to-face visits. It allows for triaging. There's a lot of easy implementation. And I'm not going to go through this in detail because I do want to leave some time for questions, but I'll just say that we're working on these systems now, and I'm collaborating with others who are really experts with this. So you'll see there's a care manager, and this is often a nurse, or in the case of diabetes, it might be a diabetes educator nurse, but it is a skilled individual who is actually communicating one-on-one with the patient. And the patient is surrounded, of course, by family, their primary care, they've got a hospital, they've got community services, etc. And what the care manager is doing is the stuff that I can't do in my clinic, and communicating with a virtual care team, which consists of all of these people, including peer supports, etc. And this is the kind of medicine that we should be practicing. So, I've got an agenda. You come to see me, I'm going to optimize your glycemia, your LDL, your blood pressure, because I know it's going to save lives and it's going to save dialysis and blindness, etc. But what you can, and that's not necessarily the agenda of the individual coming to see me. But I don't have the time. I cannot say to them, Mrs. So-and-so, what's on your mind? What would you like to speak about today? Or what's your, and maybe their primary thing that's bothering them is they're in the middle of a divorce, or they can't afford food for their kids, or something, right? So this is really holistic care. And so we have now put together a national diabetes repository. It's getting bigger and bigger. We have 300,000 people in it. We have these pathways of comprehensive virtual care where we'll identify those at the highest risk using big data and artificial intelligence, et cetera, and find out who's at risk, enroll them in this, and really provide this very comprehensive care. But it's just beginning. And I'll actually skip over this slide, but just to say, we're also developed, what we need is a registry. We need people registered like they have in Sweden and NHS, et cetera. And we're beginning to develop these. And we have one with type 1 diabetes that's just rolling out right now. So lots of very exciting things that are happening. And I'll finish off with this, that the next 100 years, I think there will be ongoing discoveries, and they're going to be exciting. And that happens all the time. And who knows, maybe we'll have, stem cells to treat type 1 diabetes, or maybe we won't. But this is where the action is. And this is what's highly relevant for your conference, is data-informed virtual care. We have to modernize our healthcare system. It is archaic, and it's not serving the person with chronic disease well. So first of all, we need to identify, using big data, machine learning, artificial intelligence, epidemiology, we need to identify the persons at higher adverse risk of adverse outcomes. And we already know, by the way, a lot of this, the social determinants really are more important actually than the genetic and biological determinants. We need to develop tools and processes for a remote patient monitoring program, reach out to those identified and offer them access to virtual care service, integrate this virtual service with primary care, develop new tools and processes for information sharing, including electronic medical records, focus on chronic conditions, screening and prevention, and at the same time, as a learning health system, evaluate the effectiveness, acceptability, and cost effectiveness from the patient, provider, and health system perspective. So lots and lots of work to be done, and we're at the very beginning stage of that. So that's it. I will stop sharing. Elizabeth, I went much longer than I thought I would, but that's because I knew I had a lot of time. And when I do that, then I speak a lot more than I intend to. And anyway.